and he'll be taking our lecture with the immense experience that he has on this topic. And this session will be co-facilitated by our own Rajgopal sir. Of course, you all know him and he needs no introduction, but he's the director of WHO Collaborating Center at Trivandrum, and he's the founder chairman of Pallium India, which we all know. So over to you, Dr. Roop Gursahani sir. We'll
Thank
start
you.
the
Can you hear
session.
me? Can you hear me clearly?
Yes, sir.
Yes, sir.
Okay, so I'm just sharing my screen and let's hope it works. Yes, so it does. Right. I'd like to begin by thanking Pallium India for introducing me to such diverse and varied audiences and allowing me to speak so widely on topics that I'm fairly passionate about. But today, my main privilege is that I'm speaking. I'll be very honest with you. As far as I'm concerned, my main audience is Dr. Rajgopal. So it's a privilege to speak in his presence. And if you look at this opening slide, that gives you some kind of idea about what we are going to cover, because this is not going to be just about practice. It's also going to be about ethics, law, because we are in a fluid situation, guidelines, because we do have adequate medical guidelines, and hopefully you will have some idea of how to proceed from this point on. But you also need to see this. I'm a neurologist, and I'm going to be speaking largely from a neurology perspective, partly also because I believe that the most difficult decisions in this area come up in neurology. So let's start with some basic definitions. And the first definitions are of medical futility. You'll see a fair number of definitions, but for me, these are the four that matter. Strict physiologic, where your treatment cannot produce the intended physiologic effect or goals. I mean, if you give an antibiotic for viral infection, you know it's useless. Quantitative, where the chance of producing a desired effect is poor. For example, less than 1%, less than 5%, less than 10%. And that is something that you will have to estimate in, say, for instance, an elderly patient who has end-stage cirrhosis and develops multi-organ failure. How will you take this forward? Qualitative, where treatment will have a desired physiological effect, but they are useless or worthless for the patient in terms of the quality of life. Or it has value-laden controversies regarding its justifiability. And we'll look at this a little further. So where CPR results in persistent vegetative state, or you give CPR in a patient who's in end-stage malignancy, and well, you might extend their survival by 1 month at the most. The last is lethal condition, medical futility, where the patient has an underlying condition which will not be affected with your intervention, and death is likely within weeks. I'm using this term weeks because, for instance, in palliative care, you might have something like extradural spinal cord compression, where surgery is indicated for quality of life, even if expected survival is just a few months. So these decisions will vary according to the patient. Now let's look at these three terms: withholding, withdrawing, and foregoing life-sustaining treatment. We use foregoing because, well, we kind of overlap withholding and withdrawing. Now, ethically, withholding and withdrawing are equivalent. And this was a line from a recent article which said that withdrawing treatment should be thought of as withholding from this time point onwards. So effectively, no difference. But legally, it varies from jurisdiction to jurisdiction. In India, in the last Supreme Court judgment, the Supreme Court has distinguished withholding and withdrawal with a rather elaborate procedure for withdrawal. Morally, in an intuitive moral sense, people do look at these two differently. Emotionally, they look at them differently. So once a process is underway, it becomes difficult to withdraw. Especially, say for instance, in these COVID times, if the withdrawal is coupled with triage. And the classic example is if you have one ventilator and two patients turn up, one who has a 50% likelihood of survival and the other has a 90% likelihood of survival, um, the 50% guy might just be okay if it goes to the person who has the 90% survival. But if the two of them come in with the 50% coming in earlier, being put on the ventilator, nobody will accept you taking the 50% off to give the ventilator to the 90%. It is something that violates our sense of justice. So you can understand that this process will have flavors that you will need to pay attention to. The next question is FLST passive euthanasia? Now, you will find a very good definition of terms which was put out by the Indian Council of Medical Research, where Dr. Rajgopal was the lead and I was one of the members. As it turns out, essentially this is the same definition from there, but this is a slightly tighter version from the same author that I quoted earlier, Brasington. Passive euthanasia is the intentional ending of one person's life by another, motivated solely by the best interest of the person who dies through the deliberate withholding or withdrawal of a life-saving substance or procedure. Now, out of this, please understand that when you talk of best interests are medical and they can be judged medically. But intention is not our business. It has to be judged legally because it takes in features of motivation, conflicts of interest. So we actually need to remove passive euthanasia from our terminology and focus only on FLST because FLST is our business, a clinician's business. It can be approached within a clinical framework. It aims to reduce suffering without any intention of causing death. There is no intention of causing death. Death is a possible byproduct of what we do, but what we are doing is basically aimed at reducing suffering. Please understand that very clearly because you will be asked, isn't this passive euthanasia? No, it is not. Right. So in all these things, we are governed by the basic concepts of biomedical ethics. And the classic four are respect for patient autonomy, which also needs you to understand that patient's decision-making capacity, look at substitute judgment, and we'll go into this a little later. Beneficence, but then you need to be sure of what constitutes the patient's good, and who decides what is good for the patient. And non-maleficence, first, do no harm. Justice, equitability, distributive justice. Again, the same thing about the ventilator. One ventilator, two patients. How do you distribute? There are additional considerations. Dignity. All persons deserve to be treated with dignity or respect. And for me as a neurologist, when I see a patient with dementia, that is something that I need to keep reminding myself. Fidelity. If you make promises, be true to them. Veracity, be truthful. And for instance, that's the basis of informed consent. Now, to make sense of these four boxes, because these are rather theoretical, you might want to look at these four basic ethics and how they are used. And the classic document is the four boxes framework, and I'll take you through them. It splits these four into combinations. So the first is medical indications, which takes beneficence and non-beneficence into account, patient preferences, which obviously focuses on autonomy, then outcomes, quality of life, which actually combines beneficence, non-beneficence, and autonomy. The last is contextual features, which is essentially about justice. So when you look at beneficence, non-maleficence, you have to know what is the patient's medical problem. Is it acute, chronic, critical, reversible, emergent, or terminal? And if you have any of these, what are the goals of treatment? Are there circumstances where medical treatments may not be indicated? And if you do undertake any treatment, what are the probabilities of success? So in sum, how can this patient be benefited and how can harm be avoided? Quality of life. What are the prospects with or without treatment for a return to normal life? And if your treatment succeeds, what kind of deficits is that patient going to be left with? If the patient cannot make a judgment, or the patient is in no position to make or express a judgment, what quality of life as an outcome would be acceptable for such a patient? Do you have biases when you do these kind of judgments? Do these quality of life assessments change your treatment plans? And if you do decide to forego, what are the plans and what is the rationale? Contextual features. Did I miss one? Yeah, sorry, I missed one. I jumped over this slide. Autonomy. Has the patient been informed of benefits, risks, understood this information, given consent? More importantly, is the patient mentally capable and legally competent? And if so, are the preferences clearly expressed? If the patient was incapacitated, were there prior preferences? Is there an appropriate surrogate? Or is the patient unwilling to cooperate? If so, why? So all of these come in, and then comes justice. Are there conflicts of interest? These could be professional, these could be personal, these could be business. Is there finance? And that's why I said some of these issues actually have to be taken out of our hands and put into legal. Are there third parties? Is there a family with an interest in the clinical decisions? Is there confidentiality when you are discussing these issues? Because third parties, especially insurance, has a legitimate interest. During this clinical decision making, are the health resources scarce? So are you going to undertake triage? Are there religious issues, legal issues? Is there a question of clinical research? What about public health and safety? For instance, when you have to forcibly put a person into quarantine because of COVID. And then there are conflicts of interest within institutions and organizations. And I work in a hospital that is part corporate, part trust. So those questions are asked, and I'm happy to tell you that at least in my hospital, I never faced those. But I know that in other corporate hospitals, these issues do come up. Okay. So what are life-sustaining treatments that we are talking about? It starts with IV fluids and medications, including antibiotics. Think about it. Antibiotics in a person with severe dementia who gets into a bad UTI, gets septic. You can actually decide not to give an antibiotic. Hemodialysis is obvious. Artificial respiration, both NIV and invasive ventilation are obvious. Chemotherapy is obvious. CPR is obvious. But what about clinically assisted nutrition and hydration? Rice tube or percutaneous endoscopic gastrostomy? Remember that once this is done for families, it becomes very difficult to withdraw. And in Abrahamic religions, this will be considered basic care and withdrawal may not be possible. So when are the considerations of FLST triggered? This was a list that was provided to me by one of my mentors, Dr. Mani, who's an intensivist in Delhi. And this list is catastrophic acute brain injury, advanced malignancy, and acute decompensation of chronic end organ failure. And I'll leave this list aside to point out the next three items, because the next three items add complexities. What if somebody has expressed desire against aggressive care? So is there a prior living will, advanced medical directive, especially if this patient is now without decision-making capacity? What about somebody who comes in critical illness on the background of irreversible and progressive severe neurologic disease, say severe dementia, or say, for instance, a young adult with bad dystrophy, and so on? Or you have somebody who's in an acute situation and worsening after a reasonable trial of organ support. Would you go on to ECMO? So these are questions that will often have to be answered. And in individuals above the age of 80 years. The last is when the surprise question is negative. I won't be going into details on that for the 6-month time frame. But as I said, I'm a neurologist, so I will be speaking mainly from my experience with catastrophic or severe acute brain injury. So you have patients who have hypoxic ischemic encephalopathy who've undergone CPR, spontaneous circulation, return of spontaneous circulation has happened, but at the end of 3 days are still pretty bad. And those are separate criteria. We won't go into that. Bad ischemic strokes where maybe one hemisphere is gone. Bad intracranial hemorrhage, either hypertensive or subarachnoid. Traumatic brain injury. Traumatic brain injury is rather tricky because very often these are young adults, and this is the one scenario where we extend our prognostic consideration and our timelines. And the last is acute on chronic brain disease. As I told you earlier, somebody with dementia comes in with a fresh stroke. Now, it's important to understand that when somebody comes in comatose with a medical condition, a medical cause, not trauma, I'm saying all the other medical causes other than trauma, and the patient comes in coma, say more than 6 hours after onset, these figures are not very good. 60 to 70% of them will die. Only about 10 to 15% will come out with mild or no disability, and about 10 to 15 will come out with about 20 to 25% will come out with very severe disability, extending to what is called chronic disorders of consciousness. Now that's a whole separate lecture. And actually speaking, this distinction in prognosis is almost entirely clinical. It may surprise you that in spite of all the advances in neuroimaging, some of these decisions can be made within the first 24 hours on the basis of a known cause of coma, a GCS which is low, and where brainstem signs are present. Now, when you are managing these patients, remember that the initial prognosis will always be uncertain, and you have to beware of self-fulfilling prophecies. For instance, in ICH, intracerebral hemorrhage, it is now known that hospitals that have care limitation policies tend to have worse outcomes in terms of survival of patients with intracerebral hemorrhage, actually. Then you have to consider whether the patient can undergo neurosurgical salvage, and that is called decompressive craniectomy. A wide bit of the skull is removed, and brain swelling can actually, patients with brain swelling can survive. Unfortunately, when, for instance, it's done in traumatic brain injury, all that you get is massive deficits and just a surviving individual. But whatever it is, a simple rule is a time-limited trial of full ICU therapy for at least 24 to 72 hours, and this satisfies economics, ethics, and common sense. Typically, within this period, brain death determination and withdrawal with or without organ donation can happen. The issue comes up if organ donation is not possible or it is refused. Can you declare brain death and withdraw life-sustaining treatment? Yes. In the Aruna Shanbag case, the Supreme Court clearly decriminalized. Now, there is a question. Somebody told me that this is illegal. If you say illegal is something that is not covered by a specific law, yes, perhaps you could call it illegal, but it is not criminal. If at all, these are issues that will be covered in the consumer courts. And if you look further, this actually is covered by the MCI Code of Conduct, where it actually says that if somebody is brain dead, you can withdraw. All that you have to do is follow the rules of the Human Organ Transplant Act. And if you look for litigation, the only litigation that I am aware of is this consumer court litigation from Delhi, where a hospital which kept a brain dead boy alive not only was forced to return all their fees, but was fined 5 lakhs on top of it. And then, of course, you have this document which came out towards the beginning of last year, 2020, where Kerala became the first state which said that brain dead patients without the planning for organ transplant, without family consent, can be taken off life support. The important thing to remember, it all depends on who's paying, whether it's a family or the state or third-party insurance, and beware of being the doctor who's caught in between. This is to show you the geo that came out from Kerala. And it is quite interesting that this whole question of withdrawal of life support in somebody who's brain dead Do you need to uh, ask the family before you do an apnea test and make a determination of brain death? Um, Actually, even in the US, this is an issue whether consent is needed before a determination of brain death, and guidance on how to respond to family objections to discontinuing organ support after declaration of death by neurologic criteria. Uh, so you can understand these are issues that are common across the world. And when death is not the question, or it is just somebody who has severe brain injury, remember that donation after cardiac death is something that is widely practiced across the world except in India. These are individuals who have severe brain injury, but who will go on to survive and become persistent vegetative state, or what is called as uh, uh, the minimal conscious state. And in these, you have to follow what is called the dead donor rule. So ideally, you have something that is covered, a situation that is covered by advanced care planning, and surrogates are in agreement. Extubation is done in the OT with harvest team on standby after the heart has stopped for a designated period, which varies from jurisdictions from 2 to 5 minutes. Organ harvest begins. Originally, only kidneys were used to come out in good condition, but the boundaries are being extended, and we now know even that even the heart is being removed. And if you want to know how this works, just read the story. It if you don't have tears in your eyes midway through it, well, I'm not sure you're human. Anyway, uh, the donations, the contributions of donation after brain death and donation after circulatory death have changed over the years. For instance, Spain is probably amongst the highest because you have presumed consent. But anyway, we'll leave that aside and come back to what we were discussing. And this is to do with communicating prognosis to families who are faced with their loved one who has had severe brain injury. Now, remember, when a patient, when the family starts talking to you, they are not doctors. They think that they are going to get this, a person who comes back to normal. And you have to predict where along this route this patient is going to land up. Now, when we communicate prognosis, palliative care physicians are better than this at this than neurologists are. But remember that whether it's surrogates or physicians, one thing is common. We all agree that there is no false hope. We are concordant on that. But on other things, we are not concordant. Surrogates want numeric estimates of prognosis, do not like uncertainty, whereas doctors prefer qualitative terms and understand that uncertainty is a natural part. Surrogates want prognostication to be done with compassion, and once they have made their decisions, they want it accepted. They don't want us arguing about it. You will be surprised that how giving numerical estimates of prognosis changes decision making. So this was a small, neat study. I don't think it's been replicated. About 80 odd anesthetists, okay, were taken as subjects, and they were given this questionnaire. They were shown three case scenarios. They were shown a CT scan and the case scenario, and uh, they were asked to vote on whether, if you were the patient, you would want a decompressive craniotomy for yourself. And after they had looked at this, given their numbers, they were then given the prediction of unfavorable outcome based on existing scores that are widely available. This is called the crash score. This is used for traumatic brain injury. And see how their decision making changed after they got this numerical outcomes. So even for doctors, it makes a difference. Unfortunately, when it comes to prognosticating, remember that till the middle of the last century, the three skills of a physician were diagnostic, therapeutics, and prognosis. But physicians now are socialized against prognostication, partly because our empowered patients now expect us to prognosticate honestly, accurately, and optimistically. And because we don't know how to do this. We are not trained in communication skills. We replace it with magical thinking and the ritualization of optimism. Again, these are all topics of another lecture. But when you have to communicate prognosis, remember that in these neurological situations, you can get fairly decent estimates. These are effectively heuristic. These are estimates. But these heuristic estimates, whenever done by experienced physicians, usually err on the optimistic side. When you do this kind of communication, at least I would use definite statements only for one is normalcy and brain death, the two extremes. She or he will never be normal again. He is brain dead. Otherwise, for everything, I allow leeway. So less than 10% chance of being able to stay alone at home, 50% chance of not leaving the hospital alive, if at all with tubes, 70% chance may not be able to recognize you. And with practice, I think I have gotten more and more comfortable doing this. And this is something that I advocate to neurologists routinely. Uh, Uncertainty is maximal with traumatic brain injury in younger patients. That's where I avoid these kind of statements. But the problem is who decides when the patient cannot? Ideally, it should be an advance directive and healthcare power of attorney. And we'll come to that a little further. It's valid, but not enforceable in India. The procedure to make it enforceable is tied up in knots by the Supreme Court. But remember, nobody stops you from making your wishes known. So you have to use surrogate decision maker. This is by convention, and I'll explain that to you. And we have very, very fortunately, sometime last year, a working document that has been released on the AIMS website, which has the guidance for AIMS faculty on withholding life-sustaining treatment. And one part of this is the surrogate hierarchy. You will be surprised that even the Human Organ Transplant Act does not have this hierarchy. It has just a flat kind of a statement of who can do it. Here is the first statement of hierarchy, and it is pretty much very modern. Spouse, de facto spouse, partner with long relationship, friend of long standing who regularly attends to the patient, then available adult children, then parents, then siblings, then others. And if there's a problem, then you need an end of life care committee. How do you use these standards? And you have to understand the difference between substituted judgment and best interest judgment. Substituted judgment is when you have a surrogate. The surrogate is told this is not about what you and the family want. This is what your loved one would have wanted. So we need knowledge of the incapacitated person's values, beliefs, and past choices. And our choices then reflect what the decision maker believes the patient would have chosen. When do you use best interests? When you have very little knowledge of the patient or the individual was never competent, and then you put together greatest benefit and least consequences, and this is called a reasonable person determination. If any of you is interested, please look at something called the Court of Protection in the United Kingdom. That is the best system in the world. If you follow me on Twitter, you'll see that there's a lady by the name of Kitzinger who keeps tweeting about the Court of Protection rulings, and her blog actually tells you how these decisions are made in the best possible way as of now. Okay, so we put all of this together into what is termed shared decision making. We are using best scientific evidence, putting it together with patients' values, beliefs, and preferences. But remember that in Asian societies, individual autonomy is not paramount. It's relational autonomy. And you need to be mindful of how that works. Today, I literally agreed to a peg for a patient with dementia, where I know that if I had gotten to the old man and asked him, he would have said, "I don't want this." But we have to be mindful of our relational autonomy. Anyway, this becomes a collaborative process where you introduce the choice, describe options with benefits, harms, and the medical evidence, explore patient preferences, make decisions, and touch back. This is not something that you can do in one shot, but If you start doing this regularly, you'll find that this does not take as long as you think it will. Uh, 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 Dr. Sushma Bhatnagar, a professor of palliative medicine at AIMS, has tabulated this, and they believe that this process, when done systematically, this discussion does not take longer than 15 minutes. And this process puts together our best prognostic estimate, but together with the surrogate who gives us their estimate of patient goals and values, and through shared decision making, we set goals of care. Coming back to neurologic injury, remember that this is not something that can happen in a hurry. When somebody comes in with severe brain injury, these decisions should not be made for 10 to 14 days. A tracheostomy and a gastrostomy should not be performed till a minimum of 10 days. This is because that is the minimum period of time that families take to decide. This is my experience, and I was very pleased when I found the doyen of neurocritical care from Mayo Clinic actually used the same figure, 2 weeks. At the end of 2 weeks, families reach a fork in the road. Either support in the hope of improvement, in which case you go ahead with tracheostomy and gastrostomy, or you de-escalate to palliative care and you go on to palliative extubation. Now, doing again, as I said, that would be a whole lecture by itself, so I'll leave that aside. Do we have guidelines, professional guidelines? Yes, we do. And this was something that came out from Dr. Mani, and he led the team that worked on this. In fact, these were guidelines that were put out jointly by the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care. So please be aware that this is a statement from the premier medical bodies associations. And I'll come back to this issue a little later. So with this, a due process for end-of-life care in these situations is now proposed. So the first is to accurately identify terminal illness, the list that we've identified, futility, establish consensus amongst all healthcare providers. There must be communication. I'm actually part of a situation where I came in because there was no consensus. Determine the competence of the patient. If the patient is incompetent, is there an advanced medical directive? Then work with the appointed healthcare provider. This is a fairly rare situation in India so far. Otherwise, you identify appropriate surrogates, make an honest disclosure, shared decision making. If there is no conflict, then you implement the plan for withholding or withdrawing life support treatment. And then finally, you review the care process. If there is no consensus between, say, the treating team and the family, then you need to go into a conflict resolution process. So, as I said, the surrogate decision makers, you need hierarchy, you need to confirm consensus. But what is important is that you complete documentation. Prepare a detailed note on the clinical condition. It has to be signed off by appropriate surrogates. Typically, for me, I follow the hierarchy. Do due diligence. If the spouse is not there, typically, very often you'll have the situation where the person who's paying is not the person who's the appropriate surrogate, and you need to make sure that this is covered. It has to be signed off by 3 consultants. That's our suggestion. And post facto, ideally, large institutions should have a clinical ethics committee, not a institutional ethics committee like a research ethics committee. This is a clinical ethics committee which has a separate functioning. This is not a body that exists in most hospitals, except as far as I know, perhaps KMC at Manipal. And you get a post facto audit. Now, if you see all of this, you will realize that end-of-life care has multiple strands. It has ethics, it has legislation, it has politics of healthcare systems. And in the COVID pandemic, we can see how politics impacts our healthcare systems. You have complex medical decision-making, and you have individual human suffering. And because this is everybody's business, government, medical, legal, civil society, it becomes nobody's business. But essentially, this is a medico-legal issue. Far more a medical concern than legal. Unfortunately, and I'm making this as a statement, instead of owning it, the medical profession keeps looking to the legal to sort it out, and that creates an unholy mess. The legal framework that we should follow starts with the Constitution of India. We follow the common law system where a lot of decisions are made by judgments, court judgments. Then, of course, we have the THOTA, the Human Organs and Tissues Act. We have Supreme Court and High Court judgments, but we have professional guidelines. And then we have other acts like mental health care, consumer protection, and so on. But remember that basically laws and judgments are a distillation of between two broad boundaries: ethics and constitutional morality. What our basic foundational software manual says, the Constitution of India, and our own practice guidelines and policies. So we are not powerless individuals. As professionals, we do influence our association, and through our associations, we do have an influence on laws and judgments. But you do need parliaments, legislative assemblies to make laws. This is because there is a gap between ethics and legal. Ethics is what ought to be. Legal begins with what is. Ethics is based on and shapes morality. So it shapes social and personal rules, behaviors, and judgments. If you violate ethics, you'll be disapproved of, you'll be condemned, and you will be removed from your WhatsApp group. For instance, if you talk politics in your WhatsApp groups, that happens in one of the WhatsApp groups that I am. What about legal? As I said, it begins with what is. It's to do with statutes and case law. It sets minimum standards for social behavior, and it enforces punishment if you violate it. Well, what do we have? The first real judgment that came out was the one that I was part of, the Aruna Shanbag court case, which decriminalized this process, just decriminalized it. It said that, again, there's a long article on how Justice Kardju confused the meanings of passive euthanasia, but it also dealt with patients who are kept alive mechanically and said if there was no plausible possibility of coming out of this state, withdrawal of support was permissible. Where are we now? We are now covered by the judgment of 2018, the common cause judgment. It followed on from two other judgments that came out together, three judgments that came out together within the span of 1 year. This was the privacy judgment, and then the consensual sex, the same sex judgment. Three judgments that came together that took liberty from the directive principles of the Constitution into our personal space. And as far as medical treatment, this judgment made it clear that we had the right to refuse medical treatment based on autonomy, dignity, and privacy. So it provided the constitutional basis for advanced medical directives and withdrawal of life-sustaining treatment. But because they are judges, they are not parliament. They wanted to make sure that this had safeguards and guidelines, but could still be used until Parliament got around to doing its basic job. When it comes to advanced medical directive, in fact, it tied it up in knots, except that what people don't realize is that it made it valid, but did not make it enforceable. Unfortunately, people mix that up, and they think that if they make a living will, a Supreme Court justice is going to come running after them. Not like that. You can make your living will, and it's valid. So, and we are about 40 or 50 years behind the rest of the world on this. If you are interested, there are some details that you will get on the Pallium India website, and I won't really go into that. So, what about withdrawal? So they suggested that whether it was with or without an advanced medical directive, the decision-making should be done by a treating team under a hospital oversight ethics committee. But then they introduced another layer, which was the district collector committee. No district collector knows about this committee. Nobody has appointed these committees. And this should be monitored by a judicial magistrate first class. No judicial magistrate first class knows that he's supposed to be doing this. And there was no mention of penalties for violation or anything else at all. So we've been told that if you go through with this process, what you can do is you do this bit, you have a hospital ethics committee, and you write a registered letter or speed post to your district collector in triplicate, asking them to provide you with this committee. It will be apply, apply, no reply, and then you go ahead and do what is right, but document it. And breaking news, if you look at this process, there has been no candidate so far. Nobody has followed this process. Well, we went back to the Supreme Court because my group was involved with trying to get this happen, to make this happen. Unfortunately, the pandemic struck just about at that time. And as you can expect, our Ministry of Health and Family Welfare, if you look at their performance on oxygen, I'm not expecting too much from them. Anyway, the group that I was involved in, then the ICMR actually took on some things that were within our remit. And one thing that was completed was the ICMR consensus guidelines on do not attempt resuscitation. Now, when you, I have about 5 minutes more. Is that okay? Yeah. So,
Yes, true.
yeah. So the DNAR guidelines, remember that CPR has been around for about 25 years. When you do CPR, it is reasonable to presume consent and attempt resuscitation when it happens unexpectedly, when you think it may have a physiologic effect and you have no information about the patient's wishes. But if the patient is able to tell you that, then you have to remember that CPR is a procedure which you cannot proceed with if the patient has not given consent. So we put out a flow chart for this, and Dr. Mani actually constructed this flow chart. And this flow chart says that if the CPR has a reasonable chance of success, no. Is the patient competent to be informed or consulted? Yes, no. If no, then you go ahead with the process of discussing it with surrogates and so on, and you do not attempt resuscitation if you do not have consent. You have to discuss this in simple language. Patients' values should be elicited, respect their choices, take decisions in their best interest, but the final decision is the physician. And CPR cannot be performed on demand, and you have to complete documentation. Now, what happens if CPR has a reasonable chance of success? The ICMR, and we argued about this, but the ICMR, well, the rest of the committee said that you do not discuss it. Actually speaking, and they said CPR should be done if there is a reasonable chance of success. It actually goes against what the Supreme Court said. All adults with capacity to consent have the right of self-determination. A competent person who has come of age has the right to refuse specific treatment or opt for alternative treatment, even if such decision entails a risk of death. The emergency principle can be given effect to only when it is not practical to obtain the patient's consent for treatment and the life is in danger. But where a patient has already made a valid advance directive, which is free from reasonable doubt and specifying that he or she does not wish to be treated, then such directive has to be given effect to. So that's where we are. So we have this document, and I would strongly urge all of you in your hospitals to make sure that the form is used. What about the rest of the world? Remember that the rest of the world, these documents are made in luridly colored forms, which are stuck up all over the place, including in people's homes, on the fridge door, and obviously in medical records, and they're called physician's orders for life-sustaining treatments. Well, what we do have is the AIMS document, which is available, which recognizes, which puts these steps together: recognition of futility, clinician's consensus, detailed explanation of prognosis, and so on, and focuses on withholding. This is because, although, as I said, withholding and withdrawal are ethically equivalent, legally is not really correct in India. To the layperson, withholding is emotionally easier. So, for instance, even if I have to extubate a person because of severe brain damage, we frame it as withholding tracheostomy. So at the end of 10 or 14 days, when the family has accepted, then we tell them that the extubation is a medical decision, but a tracheostomy is a decision that they have a right to give us directions, and they have the right to withhold a tracheostomy. And families find it easier to take that decision. Now, I'm coming close to the end of this. Please remember that we are in a situation where we do not have a law. And as I said earlier, you will say, why is this not illegal? If you use the dictionary term and people use illegal a little differently, illegal means where there is no clear-cut law. Well, yes, you could say that is illegal. But it is not criminal. Please understand me. This is not criminal. And I am an optimist. I believe the glass is half full. But the medical profession generally doesn't agree with me. They use the same for main excuse, lack of legal clarity, fear of criminal charges and litigation. Of course, there is the difficulty in establishing prognosis, which is simplest with cancer, but less so for other diseases. But I believe that it is because of lack of capacity, because physicians outside palliative care are not trained in communication skills or in end of life care. And unfortunately, patients and lay public do not realize this, and they think that this is because we have a perverse incentive, because corporatization demands that we keep our patients on ventilators. And one friend of mine quipped that a corporate hospital is where the poor cannot enter and the rich cannot leave, which is actually not true. If you look at it, if a patient ends up on an ICU bed beyond about 5 days, well, whatever interventions are possible and necessary are already done. That's a waste. The other problem is that there are not too many palliative care physicians around. And unfortunately, where palliative care is available, it's very, very comfortable working with oncology. To move it into the hospital and the ICU, and then to make the ICU do palliative care, you require a model for that. It can be integrative or consultative. This is the group of people that I work with. So this is called End of Life Care in India Task Force, which comprises 3 national associations coming together. And coming back to this integrating palliative and intensive care, this is a specific job that needs to be done jointly. To some extent, this is being done at Hinduja, but the place where it is probably being done best is KMC Manipal, and to some extent also at All India Institute, New Delhi. There is enough support for protection for life support limitation, but we have to accept that. Remember that if you look at DNAR, the ICMR is telling you that this is good medical practice. So if you do not follow it, remember that if at all there is any litigation, this is consumer court litigation, and it is not about not giving end of life care. It is about overstaying, keeping patients. And as I told you, the only case that I know about is where a hospital got fined 5 lakhs. In the West, maximum end of life care litigation is about wrongful CPR. In fact, the term for that is wrongful life. I'm going to end at this point. My email ID is there, and I'll be sharing this presentation. So if anybody needs it, I'm happy to discuss this in future also, if you want to send me an email or so. I'm going to stop sharing and open it up for discussion. I hope I haven't exceeded time by too much. Thank you, sir.
Roop, thank you. Thank you very much. Roop, you have tried to bring clarity to a situation where there is no clarity.
I hope.
The lack of clarity starts with the doctors not clear about what their duty of care is, about the society being confused, about there being no law, about court judgments being sometimes a bit conflicting. Having said that,
Yes,
you
sir.
are still suggesting a course of action which could be actually practiced in the absence of law on the subject based on the currently available Supreme Court judgments? What you are suggesting, things that could be practiced. Ru, please tell us if I make the following statements, they are correct. One, advance directives are currently legally valid in the light of the Supreme Court order of 2017 or 18, I forget.
Yes.
Though the Supreme Court has put in complicated procedures, even if they are not followed, like counter signature by the judicial first class magistrate, it is still valid in the absence of any other document.
Yes. Do you want me to explicate on this? I'll just. So again, I'm repeating what I said. They are not legally enforceable. So if your doctor picks up your advanced medical directive and tears it up and throws it away, there is nothing you can do. I'm sorry, there is nothing you can do. But remember that a proper advanced medical directive provides guidance for your family. And if it is done correctly, if you see to it that the doctor who manages you accepts it, then it is likely to be followed, very much more likely to be followed than not. So valid, not legally enforceable.
Thank you. Roop, thank you very much. The limited time available, Gloria, shall we open it up for questions or comments? You might either unmute and talk after raising your hand, or you might send a chat question.
We have a question actually in the chat box. Dr. Sashidharan has asked if insurance companies, they accept organ donation after traumatic brain death. So I'm not very sure about what insurance companies do, but I think yes, they do this. But
Yeah. I mean, all the expenses will be covered. Typically, hospitals have policies to the actual organ donation procedure. Obviously, is I mean, that's not charged for the donor, and typically up to the point that the organ donation process begins. So it's either covered by insurance. It is covered by insurance.
So, actually, I had one question in one of our previous sessions, not in this, but another course. There was a case where a person around 60 years had a traumatic brain injury and was again brain dead, like in coma and on ventilator for 10 days, during which he underwent tracheostomy, and he was tested if organ donation is possible, which came out that no, organ donation won't be possible in this case. So the family actually was told to arrange for a ventilator at home, and the hospital was not ready to take the family of the take the patient off the ventilator. Actually, the prognosis was not communicated to the family properly. But in this case, I had a question. What is the status of living will? For example, if the patient had said, "Ki, I don't want a ventilator or complicated procedures at the end of life if the prognosis is not very good," so is the hospital obliged to follow the living will of the patient irrespective of the family's view on it? So what does a doctor do, palliative care physician, in this scenario? Like, what is ethically, or one scenario is ethical and another is actual?
Okay, so I'll so it's a long. I mean, it's a complex question. So I'll answer it in terms of a story. This was a patient of mine who came in with. I think I may have even spoken about it. Who came in with locked-in syndrome. Locked-in syndrome means a pontine infarct, and he's paralyzed from this point on. And when the story began, the family obviously wanted everything to be done. And within about a week or 10 days, he ended up with a tracheostomy and he was on the ventilator. At which point it became obvious that the family could not really manage this any further. And they wanted withdrawal. So our palliative care physician, Dr. Jayarajan, was involved in the decision making. What we did was we put the patient on a smaller machine, the kind that you use for BiPAP, moved the patient to the floors, began sedation. We offered the family the option of moving the patient with the smaller machine home with a private nurse, but they decided against it. And as far as we could make out, it was not, the patient was completely unconscious. So he was sedated, no antibiotics were given, and he passed away about a week later. Now, typically when you are in this situation, this is why I emphasize one thing, and that is that a tracheostomy must not be done until the family is clear, until they reach that fork in the road, because the tracheostomy is the key distinction. At the point of tracheostomy, if you have to extubate that patient, because you cannot leave the endotracheal tube in beyond a certain period of time. But the putting in, and that is a medical decision, that is our decision. Putting in a tracheostomy is a choice that you offer them. And that becomes much easier for families to decide. And if you do that, then the withdrawal is framed as withholding. Now, there are arguments about it, but that's what I do.
Roop, thank you very much. Gauriya, there will be still, shall we just take one more question before going on to the case presentation? But I'll also, I'm happy that after the case presentation, we would practically be discussing the same subject. So there will be opportunity for more discussion. But before we start the case presentation,
Do we have any more questions?
any burning question?
Can you hear me?
Yes, Dr. Neelima.
Yeah, sir, this is also a case scenario. About a month ago, I had a patient, elderly lady who had a sudden stroke. And she had a sudden stroke. There was, brain was infarcted. So there was no way she was going to come out of that. She was comatose on a ventilator. She was maintaining her cardiac status. She was on supports, which had all been dialed down. So she was not on any supports as well. But basically, she was just comatose on the ventilator. Now, the family also did not want to continue anything further. They knew that it was end of life for her. Now, my question was, since she was near end of life, we were not giving any medications for her, but she was gasping on the ventilator. And the family found it very difficult to see this as the daughter and the son. My question is it okay to give muscle relaxants at this point of time so that the bystanders don't see this gasping happening? Is it okay? Is it not okay? What is the ethical? There was no, she was not on any sedation. She didn't require any sedation.
Roop, a very practical question certainly warrants an answer. In the sense, brings up issues like the role of palliative care, appropriate palliative care. Roop, you want to answer that?
This is yours.
Dr. Neelima.
Yes, sir.
What the person needed was palliative care.
Okay.
What you are suggesting is, with all good intentions,
yes,
giving a muscle relaxant to suppress the ventilation is an intervention that could be questionable.
Okay.
And questionable both ethically and legally.
Okay.
Whereas, if you had given a small dose of opioid,
okay,
that would have been taken away some of the difficulty. And if the patient also needed sedation, a combination of an opioid with a small dose of benzodiazepine would have been more appropriate. Roop, please comment.
I agree, sir. I completely agree. Typically, I would have, if I was this actually is a little tricky for me at times, but whenever the patient is admitted under me, Dr. Jayarajan is involved by this stage. And so I really, these decisions are taken over by the palliative care physician.
Could I just interject here, sir? The thing is, the family did not want any sedation. They wanted to stop sedation. They didn't want any intervention because they knew she was going to pass away. maybe in 1 or 2, not aware of how long it would take, but they knew she would pass away. The son was very clear that he did not want any sedation, he did not want any medications, but there was a daughter who was sitting close to her. The son was taking all the decisions. The daughter found it difficult to see the mother. They knew everything. They knew that the mother was going to pass away, but they found it very difficult to see their mother gasping on the ventilator.
Dr.
At the same time, they didn't want any medication. So how does one deal with such situation?
I will,
it's very
Dr.
difficult.
Neelima,
Yes, sir.
in view of the time constraints, I'll give
Okay.
that response to that question and then move on to the next part.
Okay.
If the family did not, or the decision makers did not want sedation, you couldn't then do it without
Yes.
their permission, because as Dr. Deepak Varghese has given here, the bottom line is not, I mean, in the chat box, the bottom line is not to be in conflict with the family.
Exactly.
Just was unwise to be in conflict with them.
Yes.
The daughter needs proper communication. And when they have said no sedation, going one step further and giving a muscle relaxant, maybe literally not violating their instruction, but in an ethical sense, that is totally, I believe, unacceptable. Maybe the son and the daughter needed to be informed. The communication was what was necessary, and be encouraged to accept what needed to be done, and explains that sedation in this case was medically necessary. So I think, considering that, I'm sorry, Dr. Neelima, I'm sure you have more issues to bring up with this. I'll introduce to you Dr. Koshi Jacob. Dr. Koshi Jacob is a radiologist from England. He is not here as a radiologist. He is here as the family member of somebody who died a few months back, and in whose treatment issues were brought up about intensive care, for example, which automatically brings on the issues of interventions. I'll also say that in addition to being a radiologist and a family member of a patient who received end-of-life care recently, he is also a great human being. Dr. Koshi, I know how busy a person you are. Thank you for agreeing to do this and share this story with us, following which we would still have some time for discussion.
Yeah, thank you very much. I hope you can all hear me well. And it's a real privilege and pleasure for me to present this to Pallium India. And I'll just go straight to the presentation, and then we can discuss a bit. Okay, so let's go to the first slide. So this is about my father, who was quite a well-known scientist. He was a physicist. He had a very illustrious career, and he was a fellow of the Institute of Physics. A very intelligent guy. And around 72, 73 years old, he was actually quite fit and well, and he started developing memory loss. And to start with, the things that the family usually go, we told you about that, all those kind of questions, but you can't remember. And it led him from being a very intelligent, very in control person to someone who lost confidence in himself, developed increasing dementia, and he'd had albumin in his urine for a long time, but we kind of ignored that because there was nothing wrong in any of his bloods. He was healthy. But he used to smoke many years ago, 30, 40 years ago, and he basically started developing vascular dementia. And when he was admitted into the hospital, his sort of deterioration started in July last year, when he was admitted with seizures, which actually ended up to be secondary to small vessel disease. And he was at that stage put on to a whole lot of medications, anti-seizure medicines. He was put on atorvastatin and clopidogrel and aspirin and a lot of different drugs. And in December, he got admitted with an acute and with a urinary tract sepsis. He was admitted to a hospital in Trivandrum, well-known hospital, and he was straight away taken into ITU and treated there with IV antibiotics. But before that, I'll just say he also had multi-infarct strokes. He had IgA nephropathy, we think. And I mentioned seborrheic dermatitis and hiccups, which he developed, because we don't often, as doctors, pay enough attention to these things. But sometimes these are the things that really affect the patient the most. So he presented with weakness. I'm just taking a screenshot from the discharge summary with generalized weakness, blood in stools, known vascular dementia, and had all these different symptoms. Was taken into ITU, given IV antibiotics, developed some improvement, mild improvement in sensorium, improvement in renal function. Remember, he came into hospital disoriented, almost unconscious, GCS probably around 5, maybe 6. I'm not sure because I was in England. But and that was just during the lockdown, obviously, in the UK. And I somehow managed to get an emergency passport and managed to get to come to India. And at that stage, he had been moved back from ICU into the ward, and was admitted again into hospital, into the ITU with pulmonary edema. It turns out he had a troponin I, which was high. He had a heart, ACS, and he was given NG feeding. And the issues that he faced was, number one, he couldn't tolerate the NG feed. He hated anything to do with masks. Even though he was unconscious, he had he was tied up to the bed. And you could see when I came from England, the first thing was, here's a man who was totally distressed, but couldn't express himself. He was, with his hands tied, he was catching on to bystanders, and it was clear that he was uncomfortable. So I met the doctor. I explained to him that it sounds like he's uncomfortable and we need to do something. And it just seemed clear that the doctor's main task was to try and medically cure him. There wasn't any discussion about how does he feel, what can we do for him, and we'll discuss this later, I think. And he had hiccups, which straight away they said, okay, we'll get a gastrointestinal GI opinion. We need to put a gastro OGD, see if there's any inflammation. He had depression and sensorium, get a neurologist in, get a dermatologist in for dermatitis. So the typical kind of Kerala medical treatment in a hospital. Now, I trained in CMC Vellore, but I have worked in Kerala for 2 years before I came to the UK. So I kind of know how things work there. In not everywhere, but in some hospitals anyway. He was given a pneumococcal vaccine. I have no idea why. He was the Foley's catheter and Ryle's tube removed on the request of bystanders, is what's written on the discharge summary, because clearly they wanted to send him home with all these things. And we insisted that, this is not a quality of life that he would have liked, to be tied up because they had to give him medicines. And you'll see why. I'll just skip this just to say that we refused the OGD. He had ultrasound, which was normal. I don't know why they did it. CT brain just showed that it was still the same. He had a lot of treatment. His creatinine was quite high at 6, urea very high, probably the cause of hiccups. And he had a hemoglobin, for which he had erythropoietin, and I'm not sure if they had any blood transfusions. The psychosocial aspects are that he had advanced dementia. My mom was also old. She's 72. She needed a carer. 74. I mean, my sister's family were around to help, but there were lots of issues with, trying to trying to give him medication. And this was the list of medications he was given when he was left from hospital. And it's incredible for someone who has severe dementia, who realistically speaking had very little chance of a long-term improvement. He had a massive list of medications, which if you go down there is justification for every single one. You know, the lever pill for seizures, the pantoprazole for probably treating the medication, and then on and on and on. You know, you have loads of medication there that will treat individual symptoms. But our main concern is he's got, as I said, advanced dementia. We had to give him NG feeds in order to give him medicines because he wouldn't swallow them. He had a very low quality of life, and he'd had for at least 6 months before. And speaking to a consultant colleague of mine in Manchester here, he had predicted back in July that he had about a year left. So we had these very difficult questions, you know, um, and and my main concern, I suppose, was we as doctors, I had access to a whole lot of opinions. Consultant colleagues of mine in the UK and abroad in America, who were all colleagues of mine in Vellore, who have now, became specialists. I had the amazing opportunity to speak to Dr. Raja Gopal, who was recommended to me by a consultant colleague of mine in Vellore, who is Dr. Vinod Abraham, who put me on to Dr. Rajagopal, who called me up, and I had a very useful discussion. But the question is, how many people have that kind of input? You know, you have a mum who was very supportive, who said, I don't want him to suffer. I had a family who questioned the fact of, if you don't put an NG tube, are you not feeding him? Will he die because of hunger? And there was this whole issue of hunger, how will he cope with hunger? But he was uremic, and uremia probably explains a lot of the symptoms, things like hiccups and confusion. So we had to consider, do we go into dialysis to reduce his uremia? But then what's the quality of life with that? Going to hospital 3 times a week to get dialysis. I had access to so many people. So I suppose when we looked at the presentation that Dr. Roop gave, the main issue, I think, if I looked at those 4 things, it was probably the qualitative. There was going to be very little benefit from intervention. So we ended up stopping all medications, and we treated what we saw as symptoms. And he actually ended up with I don't know if I would say a pleasant death, because by the time, the day that he actually started developing air hunger was the day that I managed to go to Pallium and get some morphine. Gave him morphine at around 4 o'clock in the afternoon, and by 5 he had passed away. So it was clear that, and you sometimes wonder, did the morphine hasten death? I believe it allowed him to relax and just die. There are some, obviously, we've got a lot of questions around this. What we do, you end up reminiscing, you start wondering, did I do enough? Did we allow him to die? Should we have done more? So from a patient's perspective, those are the kind of questions that, those of you who have lost parents will be thinking if you've been actively involved in his care. And I think that's all I want to present at this stage, and I'm open to questions. But I think it was just interesting. This whole experience opened my eyes to palliative care, and I'm a big supporter. I realize there isn't a lot, and I'm incredibly thankful for the work that Dr. Rajagopal and your team do in India. And I am a supporter as well. Our organization does try and contribute. We did a fundraiser recently in the UK, which I think probably between the 2 organizations that were organizing it, I'd say, we raised about 8 lakhs. So I'd like to continue, doing that, because I believe this is a great project.
Dr. Koshi, thank you very much. Thank you for the presentation, and also for all that you have done to continue to help us to continue the work. Roop, there are a few issues that have been brought up. Some are basically core issues, like you mentioned the qualitative point. Would it have benefited? I would go one step further. Would the interventions and intensive care not only not benefited, would he have given him more suffering? That is one point. The second point is, you touched upon that how much troublesome the dermatitis was, how much troublesome the hiccups was. Those are things that are systematically ignored generally.
Yeah.
Nobody looks up how hiccups is managed, and except for palliative care physicians and very few specialists, nobody really bothers. And on the part, whereas if it was a slight biochemical abnormality, the system would take it seriously. So that's another point. And a final important point could morphine have hastened death? Dr. Koshi, right now, I can't remember what dose was administered.
I think it was 10 was it 10 milligrams?
In that context, we do not give 10 milligrams. Usually for breathlessness, the dose is given as 2.5 or 5 milligrams as the.
Well, it might have been I can't remember. It can't be 10 then. It must have been a much smaller dose.
Yeah, thank you. So Roop, a few questions that came up here was apart from the fact that the qualitatively the life support would not have improved things. Could it have made him worse?
Agree.
Secondly, Roop, this also one more question specifically to you as a neurologist. I think there are enough guidelines, especially in people with dementia, about the presence of a nasogastric tube. The same thing. Would it actually improve quality of life, or can it actually cause harm and hasten death by causing aspiration?
So I'll answer this. So
yes.
Okay. I'll answer the second one first. And if Dr. Shaka you want to put on those questions that you listed, we could probably even address them, since I think you do have that, you already formulated them. But as far as the feeding tube is concerned, I think there is enough evidence now. There is guidance out, at least if somebody checks out on, I can share that with literature as well, which says that for people who have severe dementia, the standard of care is hand feeding and not tube feeding. The incidence of aspiration does not change at all, and in fact, it avoids a lot of medical complications that come up if you insist on artificial feeding. The other part of it, which was part of the first question, that was about managing him. I think I did not see haloperidol in that list of medications that he got.
No, that was something that Pallium recommended afterwards. We put haloperidol and buscopan.
Absolutely. Buscopan maybe not in dementia because it can impair memory. So, but haloperidol is more than enough.
And it was for the buscopan was for the hiccups.
Okay, buscopan. But once you've gotten haloperidol in, you find some benefit from that as well. So 0.25 to 0.5 milligrams 3 times a day to start with. Then tapered down to twice a day, then tapered down to once. And patients are pretty much comfortable and manageable with that.
Dr. Koshi, can you share the screen and put up those questions once more?
Your last slide. Slide.
Yes, sure. Yeah, okay.
So qualitative, yes, I agree. Hospital, see, this is one comment that I do want to make. It's unfortunate that even though Kerala is the home of palliative care in India, you will get the best palliative care in Kerala only outside the big hospitals. You will get better palliative care in the villages of Kerala.
Yeah.
It's unfortunate but true, but modern medicine is a barrier. And that is where we are, regardless of whether it is Kerala, that is a barrier we've not been able to get past. Expensive treatment and medications, yes, I agree. Should we have done more? Could he have become less confused if he had dialysis? No, I think, given a choice between dialysis and a small dose of haloperidol, I would probably have tried the haloperidol first. Yes. It's yes, you are a doctor, which is why he actually got, I think, finally a dignified and a comfortable home. And you had access to Dr. Rajgopal. It's not always possible. I agree with that.
No. Yeah.
Roop, one of the things that you mentioned related to Dr. Koshi's question also relates to a question that Dr. Manisha Jaiswal has put upon the chat box.
Sorry, sir, Dr. Broderick also commented. I think she's just commenting on the NG tubes bit. So can we ask her to unmute?
Anne, would you like to unmute and speak up? I didn't even know that you were here. Dr. Anne Broderick from...
I'm here every Saturday. I was just commenting that hand feeding is the standard of care in patients with dementia. It is socially interactive. You're literally handing food and watching that patient with dementia like a hawk. I'm not sure what the right bird is in India. You're watching very closely if there's any sign of coughing. And there's a question about aspiration. Aspiration can happen with NG tubes. They can happen. NG tubes do not prevent aspiration, and you might even argue that having an NG tube through the esophageal junction allows more gastric contents to come up. So the clear evidence, at least in the United States, is that when in the 90s, we put nasogastric tubes in patients with dementia all the time. And what it led to through data that we can get through Medicare is more restraints, and restraints led to more pressure sores. So I really think the kindest thing we could do with people with cognitive disabilities is to feed them with love and by hand. So that's my passionate statement about NG tubes. And I do understand when you have a list like Dr. Jacob's father of 23 medications, how are you possibly going to give all those medications? It is certainly time to deprescribe those medications that are not designed for comfort. So I'm off. You asked me to speak, and now you may ask me to stop speaking.
No, and that restraint, that is the biggest problem that I find with nasogastric feeding, more than that possibility of aspiration or irritation. Invariably, the person would pull it out. So you tie the person's wrists and ankles. It's the most horrendous infliction of suffering to the person. And very wisely, Roop pointed out, and I totally agree, that the poor get so much better end of life in Kerala, at least. If you have any money, you really pay a lot, right. Not only in terms of money. Deepak Varghese, Dr. Koshi points out that for the hiccups, what was given was not Buscopan, it was baclofen.
Baclofen, sorry, baclofen. That's right.
And also, I totally agree that hand feeding it's not only something that helps the person, it's also the satisfaction that the family member gets. Harimohan asks, what about the risk of aspiration in oral feeding? It was mentioned already, but maybe it's necessary to reinforce that statement. And you mentioned that. Harimohan's question is, what about risk of aspiration in oral feeding?
Yes, sir. I understand, sir. I got it now.
Okay.
I was also looking at a link and I got to know that. Thank you so much.
So coming back to Dr. Manisha's question.
Yeah.
Do you blame the healthcare system in the country? Where is that question?
Yeah, it says, do you blame the health system in India? Would he be treated differently in England? Now, I have done a core medical training in the UK, so I did the MRCP, and I would say that the one difference between the healthcare system in India and in the UK is that one is highly privatized, and therefore there was clearly a pressure on two things. One is there's a big litigation risk in India. Doctors are very careful of that, but also there is clearly a need for healthcare providers to earn more money, and therefore they do end up getting a lot of treatment that can be justified, absolutely justified, but is questionable in terms of these questions that are a lot more. Whereas in the UK, the system is state funded, and therefore every consultant has to think carefully about the tests and the medications they give. So we don't give the latest antibiotics. We don't give the latest ACE inhibitors. People get, Ramipril, for example, and they don't get telmisartan, and you would give losartan instead. So a lot of the drugs that we use, we look at the cost versus benefit, rather than trying to get that incremental 1% improvement for someone who's 75 years old. To give him a 1% improvement in lifespan is probably questionable. So he would have been treated differently in the sense that there is a lot more awareness of palliative care in the UK, but even we are not there yet. Even England, and we investigate, we sometimes over investigate, and I have been, as a radiologist, I know that many of the scans that are being sent, for example, just take a CT scan, getting someone to get a CT scan in someone who is not well is a very uncomfortable procedure, but we order CT scans and ultrasound left, right, and center, so we are very conscious of that, but are the clinicians,
Thank you. Thank you very much. Our time is up, but I'll take a liberty and just come to a comment that Dr. Manu John has written. I'll just bring out the relevant part. Many doctors in India overtreat, maybe due to fear of litigation and due to lack of awareness of palliative care principles. Manu, I would totally agree. We have evidence that in Western Europe and in USA, in the face of futility of treatment, the futility that Dr. Roop Gursahani talked about, the majority of patients, the percentage would vary from anywhere from 60 to 75% of patients have their artificial life support stopped and palliative care given instead, withdrawn from futile artificial life support, whereas Indian figures are only 22%. That means 78% people are continued on artificial life support even when considered futile. And one other point, Manu, when I talk to doctors, there is this question of lack of clarity about duty of care. What's the duty of care of a doctor? In UK, that is defined by law. In India, it is not. But the Indian Council of Medical Research document that Roop talked about says that the healthcare providers' duty of care is to mitigate suffering. It is to cure sometimes, to relieve often, and to comfort always. And there exists no exception to this rule. But this is something in an obscure book in the library which nobody ever looks at. And you ask young doctors recently qualified, and the vast majority genuinely feel that they have a duty to keep the heart beating at any cost. Nobody talks about mitigation of suffering. This is a reality. And it's quite understandable because dead people, the dissatisfied dead, as John Hinton said, the dissatisfied dead cannot noise abroad the injustice they have received. We can't hear.
Dr. Raj, may I hop in for just 2? I know we're over time.
Yes,
I do want to make sure that the attendees understand that there are indications for nasogastric tubes. As palliative care physicians, we are not against every nasogastric tube or every gastric tube. There are definitely indications, head and neck cancer, esophageal cancer. There are situations where nasogastric tubes are appropriate. I know our very first session, the patient had a nasogastric tube, and I just want the attendees to know the difference between futile nasogastric tube and a nasogastric tube that helps people gain nutrition during their serious illness. I just don't want us to sound like we are anti all nasogastric tubes.
And that was an important point to make. Thank you very much for making it. Gauriya, time is well past.
Yeah, we are already 4 minutes or like some time. We have exceeded the time. So I hope all the questions were answered. And in case anybody has any more questions, maybe they can email it to Dr. Roop or Dr. Rajgopal sir, and they can be answered. But this was a very enlightening presentation by Dr. Roop, and very, very good case presentation done by Dr. Koshi, and the practical aspects summarized by Dr. Rajgopal sir. They are like very, very applicable in India, and also the insights from Dr. Ann. So they've helped us in this scenario, and I would close this session, and so goodbye to you and good evening to all of you.